Well, good evening and welcome, everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville, and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health experts in cardiothoracic surgery will answer your questions about heart valve surgery options. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. All right, well, with that, I want to go ahead and introduce our experts for the evening, starting with Dr. Pavan Atlori, who is a cardiothoracic surgeon, and also Dr. Timothy Messelbeck, also a cardiothoracic surgeon. Well, thank you both so much for joining us. Before we dive into the questions, which I know we have a lot, so an exciting discussion ahead, but I will give each of you a minute or two to just say hello, provide a little background information about yourself. So Dr. Atluri, we will go ahead and start with you. How are you doing this evening?
I'm good. How are you, Sarah?
Doing well. Thanks for asking.
Yeah, Pavan Leary. I'm one of the senior heart surgeons at Jefferson Health. Very happy to join the team, and I've been a member of the team now for 8 months. So, um, as well as my colleague, I've got a very broad experience in valvular heart disease with particular focus in mitral valve disease.
All right, terrific. Well, thank you. Excited to have you here. And Dr. Misselbeck, how are you doing this evening?
Thank you very much, Sarah, for helping facilitate this and for everybody watching. Uh,
Absolutely.
so I've been in the Lehigh Valley for many years. I actually did some of my training here as well as in Texas, and uh, I've been on the staff for about 15 years. And like Dr. Lori, we all do a pretty broad range of heart surgeries. Uh, we tend to specialize mostly in valvular heart surgery as well as uh, bypass surgery, aortic surgery, and whatever else patients may need.
Okay. All right. Well, thank you both. I know that we have a great discussion ahead. As I mentioned, we'll go through our submitted questions first and then get to our live questions at the end. So, as we're going through the discussion, audience members, please feel free to submit your questions and we will get to them. But for right now, I'll go ahead and kick us off with the first question. Dr. Atluri, I will turn this one to you. What symptoms indicate that it is time to have heart valve surgery?
Great question, Sarah. There is actually a whole spectrum, from probably the most common, most severe that we often will see is shortness of breath. And it does not have to be at rest. It can be as simple as, hey, I used to be able to climb a flight of stairs without getting short of breath. Now I'm starting to get short of breath. I exercise. I'm an avid cyclist. I used to be able to bike 2 miles without an issue. Now towards the end, I'm getting short of breath. And perhaps the most insidious are those patients that have a murmur, they're very well compensated and have no symptoms, and they're often the most challenging. So you can actually be asymptomatic and at the same time have a valve which is at sort of the stage where it needs intervention, either repair or replacement. And your cardiologist, our whole team of experts in cardiovascular care can provide you guidance in terms of what the right management of that would be.
Okay. So I guess a note to always talk to your doctor. Okay, perfect. Moving along here to question number two, Dr. Misselbeck, we will turn this one to you. What should I expect after a valve replacement, and what are signs the valve may be failing? Oh, I think you're on mute.
Of course. I want to kind of reverse the question because I think when valves are failing, just like Dr. Lori mentioned, I think oftentimes it's insidious, meaning maybe the first things are exercise intolerance, and you really can't perform the same things that you did before. And patients may actually not, they may be in denial for a little while. And it's often family members who help say, hey, you're not able to do this, you're lagging behind, you're short of breath. And they help the patients realize, hey, maybe it's time to see your doctor and talk over some of the symptoms. Uh, because it's not often always old age or I got a few extra pounds, the things we all encounter. It could be something more serious, and doesn't always necessarily mean you need immediate surgery, but these are things that we encourage patients to go to their physicians and discuss. And the short answer of what to expect after valve surgery is you should feel better. That's the goal, to feel better and to live longer. Specific things with how you do postoperatively, that depends on how sick the patient is, the type of surgery they had, and maybe we can go into some of those things later in the webinar.
Yep, absolutely. We will get to that. So, all right, thank you. Dr. Atluri, we will turn back to you here. Why is surgery sometimes delayed until stenosis becomes critical instead of operating when it is severe?
I think that's a great question. I assume you're referring to aortic stenosis. In particular with aortic stenosis, we've got a very extensive body of literature that shows us that the moment you start developing symptoms, your survival is diminished. And that's been borne out over the years and really goes back almost 4 decades. And we know that when you've got shortness of breath, chest pain, syncope, that 50% of patients are no longer alive at 5, 3, and 1 years. So we've got more and more data now to suggest that those patients are asymptomatic with severe aortic stenosis, may in fact benefit from earlier intervention and would have longer survival if intervened at the stage where we consider them to have severe aortic stenosis. So I do think that our practice patterns are changing. And this is why it's such a great field. It's very data driven, and we're always focused not on long-term survival, but also on protecting quality of life. So to answer your question, we often wait for symptoms, but more and more now we're intervening when patients have severe asymptomatic aortic stenosis, and there's actually some suggestion that maybe we should even be doing this earlier at a moderate aortic stenosis stage, which is a trial and research that we're currently involved with.
Okay, well, exciting to hear. We'll stay tuned. Thank you. Okay, Dr. Messelbeck, coming back to you here. What are the treatment options if a repaired valve becomes regurgent again?
Well, the short answer is it does not always mean that you automatically need to rush right back to the operating. So I hope that makes everybody feel a little bit better. However, valve operations, there's valves that we can repair and there's valves that we replace. It's sort of a subtle difference. But when we repair valves, the goal is for them to last usually a lifetime, depending on the conditions. When we replace valves, oftentimes there can be a finite lifetime that we have expectations for the patients to understand. And it's often set up that we have other therapies short of traditional open heart surgery, where we could put valves into, we call them percutaneous valves, for instance. Transcatheter valves is another term. So those are options. There's also a developing armamentarium of percutaneous devices, meaning devices we could put into the veins and the arteries of the patient to avoid another open heart surgery. But sometimes it is necessary for another open heart surgery way down the line, but that's becoming more and more unusual. So I think patients can have the confidence that our goal is to have the patient undergo one surgical procedure rather and with the options of other things short of open heart surgery to fix them and provide a longer lifespan.
Okay. All right. Thank you. Okay. Next question, Dr. Atluri. How long do replacement heart valves typically last, and what factors affect durability?
Yeah, I think that there's multiple factors. One is there's really two major categories of heart valves for replacement. One is mechanical valves, most often made out of pyrolytic carbon or some combination thereof, which often can last a lifetime. Annual fail or lifetime failure rates somewhere right around 6%. So the excellent valves can really go for decades. Bioprosthetic valves really depends on the position. Um, And it really depends on the data set that you're looking at. In general, we tend to think that bioprosthetic valves in the aortic position somewhere between 15 and 20 years. There's many data sets that would suggest the median um, survival or durability of valve right around 16 years. The mitral position tends to be a little bit less and more in the 10 to 15 year range. And then the final factor is age and comorbidities. Those patients that are younger tend to have valves that last a shorter period of time compared to older patients, which is why we're very hesitant often in patients in their 20s and 30s to put in bioprosthetic valves. And also certain factors like renal failure tend to lead to earlier degeneration of bioprosthetic valves.
Mm, okay. All right. Well, thank you for walking us through that. Overall, sounds like it can depend, but thank you. Okay. Dr. Misselbeck, question for you here from the audience. Can heart valve disease cause electrical conduction problems such as bundled branch block? Oh, we may have lost him.
Uh,
Can you
I
hear me?
had a little technical glitch there. Can you repeat the question?
Oh,
Everything.
absolutely.
Yeah, sorry.
No, no worries. Okay, this question for you here. Can heart valve disease cause electrical conduction problems such as bundled branch block?
Yes. So any cardiac surgery, especially valvular surgery, patients are at risk for electrical disturbances. And bundle branch block is certainly one of them. Another one may be something more serious called complete heart block. The incidence of those, uh, when I talk to a patient about the risk of surgery, we often talk about, catastrophic risk, and those are generally very, very low. When we talk about other risks that are non-catastrophic, such as electrical problems or potentially needing a pacemaker, uh, the those risks are probably less than 5% in general. Now, patients who come into the operating room who already have electrical disturbances, of course, they may be at higher risk, but a patient who comes in with a normal conduction system, uh, it's much lower. But it is a known risk, and it's what I tell patients. It's more of a nuisance complication that they can live with. They may need a pacemaker at worst, but they're still going to go on and have a normal life.
Okay. All right. Thank you. And you mentioned pacemaker. That brings me into my next question here. Dr. Lurie, when is a pacemaker needed after valve disease or valve surgery?
In general, when someone has what we classify as complete heart block, that's usually our trigger to implant a pacemaker. Complete heart block is when the conduction system for the heart is disrupted in such a manner that the collecting chambers of the heart, the atria, are not conducting through to the ventricle. And so hence you don't have that synchrony. And if it's bad enough, can actually lead to call hemodynamic compromise, where there's not enough blood flow to the body, a patient arresting, et cetera. And so we're very vigilant in the post-operative period. As Dr. Misselbeck said, the conduction system lies very close to both the aortic, mitral, and tricuspid valves, really all three. And so with any one of them, it's a known risk factor. So we're always very careful to monitor and if needed, implant the valve. Some patients with pre-existent valve disease, usually calcific valve disease, that involves either the mitral, but more commonly the aortic valve. can have calcium that actually involves the conduction system and can develop heart block. Um, and so early on, much of our screening, EKG is usually the most common, but sometimes we'll put monitors on patients that can monitor rhythms for longer periods of time if we have suspicions that this could be happening so that we can act on it quickly.
Okay. All right, thank you. Okay, before we go to the next question, just a friendly reminder to drop any questions in the Q&A as they pop up for you during our discussion, and we will get to the live questions in just a bit. But for now, Dr. Misselbeck, we will turn back to you here. If valve disease is moderate, how long can surgery safely be delayed?
Extremely common question, and I think it's good to discuss this. So uh, each patient is different, obviously, and in modern medicine, and I think this is a great thing that patients have access to their records. I have access to mine. I go on, I look what the test said, I read the report, and not human nature is to tend to look for certain words: moderate, mild, severe, and just because a valve is judged as moderate on any certain test, you have to realize that's a snapshot in time. So I think it's really crucial that the patient have discussions with their cardiologist, with their primary care, with their surgeon to determine that in the context of a greater overall picture. Because yes, moderate alone can often be monitored for really long times, but there's a lot of other factors that we put into play, such as family history, progression of symptoms. The longer we know a patient, we can sort of predict a little bit more of the future, and it really needs to be individualized. So I don't think that um, in general, I think it's safe to say that we don't traditionally treat moderate disease with immediate surgery. Oftentimes, those patients can be watched. Now, if we're going to operate for, say, a coronary bypass and the patient has moderate disease, hey, while we're in there, we may fix that valve to prevent a problem in the future. That happens and deserves discussion. But a lot of times, patients ask that, how long can I wait till surgery? Well, you never want to put off the inevitable, but with moderate, it deserves at least a discussion that there may be more time rather than with severe, which is more straightforward. And the good news is with severe, patients often feel pretty poorly, so they're wanting surgery to feel better.
All right. Thank you. And now, kind of getting into our next question here, post-surgery, Dr. Atlori, what physical limitations, this person says, should I expect after being discharged from valve surgery?
Yeah, I usually tell my patients there's sort of a couple of major buckets where you'll notice that you feel off. One is energy levels will be decreased. We know that with any major surgery, not just cardiothoracic surgery, but really abdominal, orthopedic, etc. They can expect weight loss upwards of 20% of their ideal body mass. And that usually returns as the catabolic state following surgery corrects itself, somewhere right around 2 months. Um, and then sleep cycle that can be altered. Often patients notice that they aren't able to sleep quite as well at night. They take naps during the day, and it all sort of, as a broadly speaking, rolls into a general feeling of fatigue. And that's all very normal after surgery. And I'm very clear with my patients, is cardiothoracic surgery is real, cardiac surgery is real. And it's usually got somewhere between 6 and 12 week recovery, depending on patient's age and comorbidities, other risk factors.
Okay. All right. Good expectations to keep in mind. So thank you. All right, Dr. Misselbeck, are there effective alternatives to open heart surgery for valve disease?
Yes, yes, and no, of course. Um, a lot of times I tell patients that valvular heart surgery is a mechanical problem, meaning the valve is not opening and closing properly. So, short of a way to fix the valve, it's not something we can treat with medicine. So, when you look at can you avoid open heart surgery? Yeah, maybe we can do other things such as transcatheter valves that we're going to talk about later, things we can do through the arteries and veins. Yes, there are alternatives as far as that goes. But are there any medications that can fix an aortic valve or a mitral valve that's not working properly? That cannot be fixed with medicine, unfortunately.
Okay. All right. And as we're discussing surgery options, Dr. Atluri, how do minimally invasive procedures such as valve clips compare with surgical repair?
Well, I think there's actually two buckets. Often patients will think of the groups or transcatheter therapies, which are procedures that are done with needle sticks, um, often through the groin, versus minimally invasive surgical techniques. Now, thinking broadly about minimally invasive, it's basically approaching the valve with the idea that you're going to achieve the same surgical result through a smaller incision. It is still surgery. It's still in many ways open heart surgery, but it's done through a small incision. Often it's done through a small incision on the right chest, as opposed to the traditional incision down the middle of the chest. The other option is, as Tim referred to earlier, transcatheter therapies. Those therapies where we approach valves through the groin. The broad category, the one that's really truly common, is TAVR, transcatheter aortic valve replacement. And we do several hundred of those a year. It's got a good result. We'll have to see what the long-term data shows, but right now it looks like it's very good in the short term, may not be performing as well as surgical aortic valve replacement in the long term. So in terms of offering that therapy, it really comes down to how old the patient is, what do we expect for long-term survival, et cetera. And then we have the only other, we've got a couple other FDA-approved therapies. One is transcatheter edge-to-edge repair for mitral valve disease. That one tends to be reserved for those patients that are higher risk, maybe prohibitive risk for surgery, because the way those techniques work, they're okay at the valve repair, but we tend to see more progression of disease, more residual mitral regurgitation. So it's usually reserved for those patients that may not be the best surgical candidates. And then the other big area that's really been developing and one that we've been really advancing at Jefferson Health is management of tricuspid valve disease. Those patients that have tricuspid valves that leak severely, and often symptoms will include lower extremity swelling, abdominal bloating, and often, if left untreated, can even lead to cirrhosis. And for that, we have techniques both for edge-to-edge repair, as well as this new exciting valve, this transcatheter valve that we can put in from the groin to replace the valve. So a lot out there. I know it's very confusing, and all these little buckets can often get blended together, but obviously we'd be very happy to sit down and talk with patients about their options in depth, in detail, really with as much time that it takes to help them understand the differences.
Absolutely. Yeah, a lot of options available. So thank you. Okay, next question here, and we have a few more questions before we turn to the live audience questions. This one is for you, Dr. Misselbeck. What is the best treatment approach for aortic stenosis in older adults?
Well, I think first we have to define older adults. So, I'm over 50 now, so my definition personally is changing a little bit. So, in general, we tend to classify, make our decisions based on age, but age not in by itself. There's also the patient's physical condition that really plays a role because patients may be 60 years old, but they have a lot of medical problems that change our strategy. So in general, anybody less than 65 or 70 years of age, it's pretty clear that patients are going to do better with what we understand and the tools we have right now with conventional open heart type surgery. Definitely, any patient over the age of 75 to 80, we tend to favor, especially for aortic valve disease, the TAVR or the transcatheter or percutaneous approach. In that patient age, patients at that age do much better, and that can often be a lifetime solution. Patients in the middle, between 65 and 75, that's a bit more of a challenge. It needs to be individualized based on the patient's condition, other problems they may have, the severity of their disease, their unique anatomy, the situation or the condition of their blood vessels. And ultimately, it comes down to a discussion, and the patient's preference is extremely important. But I think it's key that they understand, and that's have a great conversation with cardiologists and their surgeon, and we help them make the choice that's right for them. And our job is to help them understand how to choose. And these conversations could be in depth, and they often are, but they're very fruitful, and we usually come to the right decision.
Yes, absolutely. I'm sure these questions could be answered with 20 minutes, but here we are just answering a few minutes for each. So definitely more room to discuss. Okay, Dr. Lurie, we will turn to you. I know that this has been mentioned previously, I believe, by Dr. Misselbeck, but to dive in a little bit more here, this question is, who is a good candidate for a transcatheter valve replacement and who is not?
Well, there's a lot of factors and a lot of data that sits in that area, which is probably beyond the scope of all the details, at least, of this webinar. Broadly speaking, I think anybody greater, it really depends on what valve we're talking about. How about maybe we'll just focus on the aortic valve since that seems to be the most common. Anybody over 80, I think, is a very clear-cut TAVR candidate. Anybody less than 70 is a very, at least by our societal guidelines, the American Heart Association, American College of Cardiology, tend to be better surgical candidates, just like Dr. Misselbeck said. And then between 70 and 80 is really the gray area. And that's what we're really trying to tease out. And it all comes down to, as he said, what are your comorbidities? What are your risk factors? And at the end of the day, it really comes down to what's your long-term survival. What we never want to do is have your valvular heart disease be the limiting factor for your survival. And so as we give suggestions, recommendations, it's all taking into account a matrix of risk versus protecting survival.
Okay. All right. And as a follow-up to that, Dr. Misselbeck, can you talk to us about the risks associated with transcatheter valve procedures?
So it's a very interesting question because there's a perception that just because the valve can be put in through the artery, often in the groin, and the patients go home the next day with a Band-Aid on their leg. There's zero recovery or very minimal recovery compared to open heart surgery. That doesn't mean things can't still occur. We're putting a valve inside the heart. And when I tell patients that, like, yeah, you're right, we're putting a valve inside the heart, I use the analogy, it's like we're building a ship inside a bottle. It's very delicate. And believe it or not, the risks of open heart surgery are quite low. And as far as major risks, as far as not making it through the procedure, having a catastrophic stroke, things like that, they're extremely similar, single digits, whether it's open heart or with a transcatheter procedure. The one risk that is higher with transcatheter procedures is a pacemaker. When we put these devices in through the groin, we don't sew them to the heart. We have to we expand them inside the old valve, and the valve has to be expanded at a certain pressure, and that puts pressure on to the electrical system. And we've come a long way. When we first started doing it, the pacemaker rates were 12, 15%, maybe higher in some situations. And now they're probably around 5 to 10% with transcatheter. Still not as low as open heart, but it's a known risk. But patients tend to do well with either open heart or transcatheter. And I think the takeaway message is that there are risks with both procedures.
Okay. All right. Well, thank you. All right. Next question here, and this is the last question before we turn to our live Q&A. Dr. Lori, what lifestyle changes or medical therapies can help delay the need for valve surgery?
Uh, I don't know if there's a lot, to be honest with you. A lot of it is just intrinsic valvular heart disease. And we don't really have any clear-cut way to minimize progression disease. The real big one would be with um, blood pressure control. And blood pressure control can help mitigate the severity of either aortic insufficiency or mitral regurgitation. But again, this is going to mitigate symptoms and not necessarily prevent disease progression. Um, the other one that we have some mild data on, nothing very definitive, is if you have a bioprosthetic valve that has been implanted, we think the calcium supplementation may decrease the survival of that valve. Shy of that, not really much in the way of exercise or lifestyle modifications that can make last longer.
Okay. All right. Well, thank you. And with that, let's get into the live questions. How this will work, we've been getting questions throughout our discussion tonight, so thank you all. I'm going to ask the question. Whoever wants to jump in, feel free, but this is definitely meant to be an open conversation. So if you both want to jump in, you can. So with that, I'll go ahead and read off the first question here, and we'll get to as many as we can before we wrap for the evening. So the first question here, this person says, I've been diagnosed with moderate aortic regurgitation. I also have aortic root dilation. Does one make the other worse?
Tim?
Yes. When you think of the aortic valve in a frame, like a door frame, the aortic valve is the door, and the aorta or the blood vessel is the frame. So if the frame gets bigger, the draft comes around the door, so the valve can leak. So that is a situation where the valve can stretch out, and oftentimes we have to treat both at the same time with repairing the aorta and the valve at the same time.
Okay. All right. Thank you. Okay. Next question here. Can the doctors explain the difference between mitral valve and aortic valve disease? Is one more significant or concerning than the other?
They're really both very important. It's hard to compare and contrast the two valves. They often will present differently. They have different impacts on the heart. Both just as important. It's just as important to address both and manage both accordingly. That's a hard question to answer.
Okay. All right. Next question here. How long is a TAVR good for? Is this a lifelong implant?
It can be. Depends how old the patient is when they start. So if you have it when you're 90 years old, I think it's got to be a lifelong implant. Um, you know, in general, we like to think of the transcatheter valve as in 10-year increments in general, based on what we know now. So it's 10 years ago, transcatheter valves did not exist like they do now. So we're still learning the long-term durability in younger patients. And a lot of work needs to be done, whether or not patients can have multiple transcatheter valves. We're not sure yet, but in the right patient, it's designed to be a lifelong solution. Um, but the rest remains to be seen.
Yeah, this is one that I mean, Dr. Misselbeck and I get this question all the time, right? The real hard answer is we just don't know. We have clinical trial data, really good clinical trial data, like randomized prospective, multi-institutional data that we're still waiting on the studies. The survival curves are very much parallel in the early phases, and then it appears that they're starting to cross where the surgical valve has better survival and the transcatheter valve's dropping off somewhere right around sort of that 8-year window. we're still waiting to see. The valve certainly will not last forever. And the question is, how long will it last? We tend to think sort of that 8 to 10 year window. I don't know, Dr. Misselbeck and I are both seeing valves that are failing, and that becomes a real challenge.
Okay. All right. Well, thank you. Next question here. We're getting a lot, so thank you all for submitting such great questions. All right. What are the criteria for repairing a valve versus replacing it?
Really comes down to how well can you repair the valve? How long can it last? In general, we tend to think that a mitral valve repair is better, correction, a valve repair is better than a valve replacement. The data is probably best, and we probably have the most robust data in the mitral space. Um, Now, as Dr. Misselbeck alluded to earlier, it really comes down to how well will that repair last? Is that a durable repair that we're going to be able to provide? Because at the end of the day, we want to look at long-term survival. We talked about valves and how bioprosthetic valves can last a certain time. Mechanical valves can last a certain amount of time, right? Mechanical valves can last a lifetime. Bioprosthetic valves, somewhere between 10 and 20 years. And so if our repairs don't last as long, the question really becomes, are we doing the right thing? And there's certain types of repairs that tend to last longer. We know certain risk factors, fibrotic disease, calcification, that tend to make valves not last as long. Infection is another one. And so this is the complexities that go into surgical decision making about which one's better, repair versus replacement.
Okay. All right. Next question here, Dr. Laurie, I actually might pose this one to you, as I know we were talking about this earlier, but if there's anything you want to expand upon, this person's asking, can the doctors tell us about how common minimally invasive surgery is versus open heart surgery? How has the field improved over time?
Yeah, I mean, it's still most of the heart surgery that we do is done through traditional sternotomy approaches, so incision down the middle of the chest. Minimally invasive is certainly getting to be more common. Some of our practices, it's a large portion of what we do. If you look at sort of the national trends, about 30% of mitral valve surgery is done by minimally invasive means, versus, I don't know, maybe 10 years ago, we were looking at closer to 10%, so that the trends are continuing to improve. Though I've given talks on this all over the world to people as we start thinking about how do you best choose patients for minimally invasive versus sternotomy. And, there's a lot of surgeons out there that, and there's a lot of zeal in the surgical field to focus on the approach. I think the most important thing to focus on is the durability of repair, the quality of the repair. As long as you can assure patients the same quality of repair, the same high level, perfect surgery, no matter the approach, then I think minimally invasive approaches are great. And the problem that I think arises and what really bothers me is I often will see many people that have undergone minimally invasive surgery and the surgery has not gone well for one reason or the other. And that's not what we should be doing.
Anything to add, Dr. Misselbeck? I see you nodding.
No, I think Dr. Lurie really summed that up well. Uh, these are conversations we have every day with patients. It's human nature to always want the least invasive. I don't want heart surgery, so you always want the least invasive option. But when you talk to the patients, they also want what's best, what's going to cause their symptoms to go away, to live the longest. And when it comes down to it, uh, they understand and that the quality of the surgery is more important than the approach.
Absolutely. Okay. All right.
Yeah, I
Thank
think
you.
it's important also, Sarah, to recognize in the audience that minimally invasive, the big benefits that's been routinely shown is recovery, short-term recovery. It has not been shown to be beneficial in the long term. And so when we're talking about recovery, the best data I've seen, usually most studies will tell you that it's 1 day less in the hospital and about 2 weeks quicker recovery once you leave the hospital. When we look at it as a return to work or return to normal lifestyle. which are all wonderful benefits, right? But not at the expense of a long-term complication, a long-term problem, or a surgery that fails. So if we keep that in mind, I think it allows us to make the right decisions for our patients.
Yeah, absolutely. Definitely important to keep in mind. So thank you. Okay, next question here. This person wants to know, how common is it to replace an aortic and mitral valve in the same surgery?
Go ahead, Tim.
It's very common. It's not unusual at all. We do it frequently. I don't know if we could put a percentage on it, but it's extremely common. In fact, if a patient comes with one to the clinic and they have a problem with a valve, we actually comprehensively evaluate all the valves, the arteries of the heart, the blood vessels. We want to do everything all at once if needed. We don't do things completely prophylactically. There has to be something that we think will go wrong in the future, but double valve surgery, even three valves at the same time, is done on a routine basis, and the outcomes are excellent.
Okay. All right. Next question here. This person wants to know about recovery. So, can the doctors talk about recovery time for different valve surgeries? How long is the in-hospital stay? How long until a patient can typically return to regular activity?
Yeah, again, it really comes down to the scope of the surgery and the physical status of a patient, comorbidities, risk factors, age, etc. In general, I tell patients somewhere between 4 and 5 days in the hospital, somewhere around an 8-week recovery until they're sort of back to 100%.
Okay. All right. All right. We'll get through a few more live questions here, and then I will wrap up with my final question for the evening. So, our few more live questions here. The next one is valvular disease hereditary, or are there lifestyle changes that can reduce or prevent valvular disease? I know we were talking about lifestyle changes earlier, but if you have any thoughts here.
Yeah, I know we talked about the lifestyle piece earlier. I think the big one would be hereditary factors. We do think that there's genetic predisposition to valvular heart disease, in particular mitral valve disease. And we just don't know what the prevalence of that is. Now, if you have bicuspid aortic valve disease, we definitely know of a familial and genetic component there. So the key there is if you have a first order relative with bicuspid aortic valve disease, it's important to be screened. And the usual screening there is an echocardiogram.
Okay. All right. Next question. Why is a second mitral valve replacement more risky than the initial replacement?
Uh, any time we have to re-enter the body, whether it's in the belly, the chest, the lung, the first surgery causes some scar tissue, for sure. We, as patients live longer, things become more complex. We're used to doing reoperative surgery. Statistically, the risks are very, depending on the situation, they can be very similar to the first time, but they're probably slightly higher just because there could be scar tissue, and everybody's scar tissue develops differently. Uh, One of the reasons that may be riskier is because the patients are older and they may have been dealing with the disease longer. So that also comes into play. Um, After a first surgery, it could be 10, 15 years. So the patient is maybe more frail, maybe have other comorbidities. But the scar tissue, the reoperative surgery, these are things that we do at Jefferson every single day. And it can usually be done pretty safely.
Okay. All right. Thank you. All right. And our last live audience question here before we wrap up for the evening. This person says, what is an elliptical annulus and how is a new circular bioprosthetic valve attached in such a case? And I'm hoping I'm pronouncing that correctly.
Yeah, they must be referring to the aortic position. Um, Often, we think of valves as circles. If someone's got a two-leaflet valve known as a bicuspid valve, then it tends to It depends on the particular individual, but can tend to be more of an elliptical shape. And this is important as we consider what the right intervention is. Transcatheter aortic valves by nature are circular valves, and what they rely on really is radial force to hold the valve in place. And so if you take a circular valve and try to have it radially expand to an ellipse, an oval, we worry about leaks around the valve. Plus, if it's too much of an oblong, the diameter is going to be right. The geometry is going to be such that you're going to have two different diameters across the shape. So it's always hard to size those valves. So you worry not only about leak, but also about potentially rupturing the annulus and having a potential catastrophic rupture. In that scenario, if we cut out the valve, take the ellipse, and put sutures in, we're able to actually reshape it with the regular, because we're now allowing the annulus to conform to the valve itself. And so that's why we think in those scenarios where you have a truly elliptical orifice, a surgical valve replacement may be a better option if the patient can tolerate it.
Okay. All right. Well, with that, I think that wraps up our live question portion of the evening. I have one last question before we wrap it up. So for the final question this evening, I would love to know, what are your goals for everyone listening in on this webinar? What would you want to make sure that our viewers take away from tonight? So Dr. Atlori, we will start with you.
Yeah, and I think the big ones are to really not minimize symptoms, not minimize something that's abnormal that you notice or your doctor notices. It's fairly straightforward to get screening done, fairly straightforward to get the diagnostic studies done that can allow us to either just medically manage or intervene at the right time so that we protect both survival curves as well as quality of life.
Okay. All right. Thank you. And Dr. Misselbeck.
Absolutely. I strongly agree with Dr. Atlori. What he mentioned is listen to your body. You know if something's wrong. Your family member, develop a relationship with your doctors. If you don't have a cardiologist, your primary doctor can refer you. You don't necessarily need to rush to a surgeon, but we're here to help as well. And we understand what it's like to have a patient who is sent to a surgeon. It's very anxiety inducing. It's scary in some ways, but we can talk things over. It's not a 10-minute discussion when you come to the office. It's not uncommon to spend an hour plus with us. We can go over things. You may not need surgery. You may need surgery. There may be other options, but we're all here to help. And it starts with you listening to your body and taking care of yourself and engaging with your healthcare physicians and other providers.
Absolutely. I think that's a great takeaway to wrap up this evening. So thank you. Well, thank you so much, Dr. Atlori, Dr. Misselbeck, for your time this evening. Such great information was shared. And I want to say a big thank you to our audience. We appreciate the time that you're taking advocating for your own health. As both doctors mentioned, talking to your doctor is that first step. So we thank you. We will be posting an event survey so you can let us know your thoughts, any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health or Lehigh Valley region provider, please go ahead and fill out the last question in the event survey. A recording of this event will also be sent to you next week, so you can rewatch at your convenience. And if there is anything anyone here at Jefferson can do for you in this time of need, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.